Welcome to this iWorld live event. I'm so happy that you're here, and I'm even more happy that I'm with Claudia Perez. Claudia, we're talking about an exciting topic here, the most exciting topic. There's nothing more exciting than optics. Everyone would agree with me.
I would.
Yes. So this is going to be a long conversation. You know how to talk for the rest of the day. No. We're going to be talking about optics in the context of multifocal IOLs. And truth be told, we really could spend most of the day talking about just that one subject.
This is true.
So let's first of all, let's narrow things down to just a few topics. I have patients who come in for who want multifocal IOLs, and I have to tell them, you are already multifocal because you've got a multifocal cornea, and a
Right.
multifocal IOL is not going to mix with that. Tell
Right.
me, we were talking off camera. You and I are obviously twins. How does this play in?
I think it's very important to understand, to some degree, optics, specifically higher aberrations, and correlate with our corneal topographic findings as well. I think that we underestimate the repercussion of an irregular or multifocal, rather, cornea, which derives from an irregular topography in the majority of cases. And I cannot emphasize enough, and I hope that it is obvious at this point, how important it is to have a topographer in our office when we're doing premium IOLs. Ideally, we have aberrometry as well, but at least a topography could allow us to sort of extrapolate what consequences those topographic findings are going to have. And I do tell the patient something similar. I say, look, your cornea is irregular and has different foci of point of foci that already will cause enough distortion to then overlap or underlap rather an IOL that has a multifocality as well, and it's going to be too confusing because it's going to direct rays of light pretty much pretty much everywhere in your retina. And so, I think that when you explain that to patients, they're actually grateful of being discouraged for the right reasons about this premium technology. Everybody feels that they should have the premium technology, but not everybody is a good candidate for it. And there's nothing worse than an unhappy premium IOL patient, because we feel really unhappy and dissatisfied with the outcomes of our efforts. So I think it's very important to sort of be able to correlate these findings in topography and aberrometry to then counsel our patient appropriately.
If I have one crusade,
I have a
it
lot.
is it is to convince anyone who does premium IOLs that they have to be adept at reading modulation transfer function curves. Okay, that's a conversation for a different day, sort of. But to put things in simpler, more tangible terms, I think the way to view it is that there's a cost to implanting a multifocal. There's a cost for a multifocal outcome, and I'm not talking about money. There's a cost
Right.
to visual quality.
I
Okay,
always say that, yes.
there is a debt that has to be paid, and I think that people starting out with irregular corneas are starting out with less money with which to pay that debt.
Yes.
So. I know I'm getting all choked up with this topic. You understand?
I
It's very, very
understand.
meaningful to me.
To me as well.
You brought up off camera too another interesting point. All of our intraocular lenses have optical centers. Usually, if the optical center is a little bit off, it's not a big deal.
Right.
With multifocal lenses, that's different, not
Right.
only because of the centration of echelettes or rings or whatever branding it is that the lens has, but because often with the designs, the central power is different
Correct.
from the paracentral power, and we need to keep things centered. Now, definitely, that's more easily said than done. How do you assure centration with your lenses
I
surgically?
use the Perkins reflex. I don't use the pupil. I think that's a mistake in my opinion, because you can have variations in the pupil centration. When you have a dilated pupil, it's a little harder to sort of assess and all of that. So I use the Perkins reflex. That's one of the reasons, among others, why I ask my anesthesiologist or anesthetist to try to sedate the patient in a way that they still can understand and follow commands without, much trouble. Because I asked the patient to look straight at the light. One thing I started doing recently, I went under the microscope in the OR and took a picture of the lights. First of all, I got to see it myself for the first time. I'd never seen it, obviously, and so, but in the pre-op area, I showed the patient this image, and I
Oh,
say,
that's so clever.
this is what you're gonna see. So when they are mildly sedated, they still saw this in their conscious, non-sedated state. They have a recollection, and so they look straight. There's three lights. Everybody should get under the microscope and start looking at their microscope and see, because we cannot tell someone to do something that we haven't done ourselves in an eloquent way. So, I show them and say, look straight into those three lights, and that's where you're going to be centrated. And I explain the importance. Everybody has to take their part in this process, and your cooperation is your part. So you lay down, smile, look pretty, look straight ahead, and I'll do the rest.
So that's a wonderful, wonderful point. So and I want to repeat some of the things that you just said, emphasize them. You said them beautifully. It's not that I'm going to say them any more nicely. It is the case with many patients that the center of the pupil is different when the patient is not dilated, and using the center of the pupil for centration is a bad guide.
Yep.
Using the Purkinje image is very helpful in a lot of ways when we want to approximate what the visual axis is. Some caveats. Number one, as you said, the patient has to be with it and has to be able to fixate. But the second thing, and this is a caveat for all of the cataract surgeons out there, you need to figure out which of the light sources is coaxial, because you need them focused in on the coaxial light source, not a light source that's not coaxial. You defeat the whole purpose. And that's, for a lot of microscopes, that's a setting. You can turn down the non-coaxial light source, and as you say, get it underneath and see what's going on. Right. But I have a question here. And I don't know what the answer is to this question. Do you think that the intraocular lens centers where you put it, or is it going to center about the geometry of the capsular bag, whatever that is, and our lesson and our work is just moot?
It would be interesting to look into that, because I've thought about this, especially in long eyes, and not only with the multifocal eye with IOL, but also with the torics. Obviously their bag has a different configuration in terms of what your final effective lens position is going to be. And I really, to be completely honest, I don't know the answer to that question, but I think it would be interesting to look into.
Claudia, this is wonderful. I feel that I've met a kindred spirit here, I've enjoyed this conversation. I hope very much that you have enjoyed this conversation as much as I have, and I hope that you realize that you have some homework that you have to do here if you're implanting multifocal lenses. And in truth, as there are different lens options going forward, the only way that you're going to be able to compare them is with these sort of topics that Claudia has just brought up. I look forward to speaking with you many more times, because there's so much more that we can cover.
This is true. I'm thinking of all the things we didn't
cover.
No,
it's marvelous. And I want to thank you for joining us for this iWorld Live event.
Take the picture of your microscope.